Almost 1 in 3 critically ill patients with invasive candidiasis may die, and according to a new large U.S. analysis, that mortality rate has remained essentially unchanged for years. That is the uncomfortable finding presented at the 2026 Society of Critical Care Medicine Critical Care Congress. The investigators analyzed data from more than 200 hospitals. They found that invasive candidiasis remains a persistent and frequently lethal problem in the ICU. Let's look at what they found and, more importantly, what this means for clinicians. The researchers used the PINC AI Healthcare Database, a large national database containing de-identified clinical, microbiologic, laboratory, procedural, and outcomes information. They identified 5,041 adults with confirmed invasive candidiasis treated at 229 U.S. hospitals. Just over half, 2,532 individuals, were admitted to an ICU. And this was an extremely sick population. Among the ICU patients, 66% required mechanical ventilation, 72% received vasopressors, and 24% were immunocompromised. The predicted probability of death was approximately 36%. Even more concerning, mortality did not improve significantly during the 6-year study period. In other words, despite advances in critical care, antifungal therapy, diagnostics, and supportive care, survival from invasive candidiasis in the ICU appears to have remained stagnant. Why is invasive candidiasis so difficult? It rarely occurs in isolation. It usually develops in patients who already have severe physiologic disruption, prolonged hospitalization, major surgery, broad-spectrum antibiotic exposure, central venous catheters, parenteral nutrition, renal replacement therapy, or gastrointestinal pathology, and diagnosis remains challenging. Blood cultures have limited sensitivity and may take time. Non-culture diagnostics like molecular assays also have limitations. This creates a clinical dilemma. Treat too late and a potentially lethal infection progresses. Treat everyone empirically, and we expose patients to unnecessary toxicity and resistance. One of the most important findings was that only about 1/4 of ICU patients were classified as immunocompromised. Approximately 64% had other major comorbidities. A central line, abdominal surgery, or gastrointestinal leak may be as clinically relevant as traditional immune compromise. Functional vulnerability is a critical point. What should clinicians take from this study? First, prevention remains essential. Meticulous central line care and early removal of unnecessary catheters are not minor interventions. Second, source control must be treated as a priority. Antifungal therapy alone may fail when an infected central line remains in place or a collection is undrained. Third, initial antifungal selection matters. For most critically ill patients, an echinocandin is generally the preferred initial therapy, particularly for hemodynamically unstable patients. Fourth, we must consider pharmacokinetics. Critical illness can significantly alter drug exposure through fluid shifts, obesity, or renal replacement therapy. We need species identification and susceptibility testing. Candida albicans, glabrata, and auris differ in epidemiology, resistance, and treatment implications. The central message is clear. Invasive candidiasis remains a major ICU threat, and improving outcomes will require more than simply starting an antifungal. It requires earlier recognition, optimized dosing, and aggressive source control. Until we address all of those factors together, mortality may remain unacceptably high.